Hi guys, my name is Terry Campbell. I'm one of the flight nurses at UCAN at the University of Chicago. I am going to try to record this lecture that will help prepare the ED nurse and the pediatric ED nurse for the precipitous deliveries that are going to come in. So let's hope I can make this work. Stay with me here for a second. And hopefully all the videos will work as well. Okay guys, let's get started. As I mentioned, my name is Terry Campbell. I'm one of the flight nurses at the University of Chicago, or UCAN as we call it. So this lecture is, oh no she isn't, a delivery emergency. So my disclosure is I have no financial disclosures. Unfortunately, I'm not that cool. But I have to give you a warning about my sense of humor. I think that I'm hilarious. Not everybody gets me. Here's the line of appropriate, and I like to dance over that line of appropriate. So again, I think I'm hilarious. Not everybody gets me. Hopefully I don't offend you too much, but you guys are ED people or pre-hospital people or pediatric ED people. So you're kind of my peeps. So I expect you to have the same warped sense of humor that I have. Okay, so our objective, we're going to talk about the clinical and behavioral signs of imminent delivery. So when that pregnant patient comes in, either hooping and hollering that she's having a baby or just quiet as a church mouse, how are you going to know if that patient's really at risk for delivering? We're going to go over the procedures, and I'm going to actually teach you guys by using some videos how to deliver a vertex baby, a breech baby, shoulder dystocia, and we're also going to talk about how we manage umbilical cord prolapse. And then finally, we're going to be discussing the transport considerations of these emergently delivering patients. So again, transport might mean interfacility. It might be for EMS coming to your hospital, or it might be within your hospital. So you've got a patient in your ED and you're trying to get them up to labor and delivery. Okay, so we're going to start out with inquiring minds want to know. So when you guys are answering the telemetry radio, the EMS often does a really good job of telling you the patient's history and what is going on with that patient. But, you know, particularly if you're in the pediatric ED and you're like, oh crap, not only is this an adult patient, it's a patient that is rudely harboring a parasite, namely a baby, right? So what are the questions that you want to ask? So the first question you want to ask is about their gravity and their parity. So gravity, super simple. That is the number of times she has been prego my ego, and it has nothing to do with what happened to them. It's just how many times she peed on the stick and she got 2 lines, right? That's all we care about. Now, parity, on the other hand, is what happened to those pregnancies. Oftentimes, when EMS is giving you their gravity and parity, they're just giving you the number of times that she's been pregnant or admits to being pregnant and the number of now living children. But the problem is that tells me very little about the patient's OB history, and that's really what you need for your risk assessment. So the para is actually broken down into 4 different lines. So the first line, or that first dash, is going to be the number of term pregnancy. So again, your patients might not know necessarily how many weeks they were when they delivered. So you just ask them, how many babies did you have that were born near their due date? The next dash in para is how many preterm. So for us medical people, it's anywhere from 20 weeks to 36 or 37 weeks. But again, we would just ask our patients, how many babies did you have that were born really early? The next dash is abortions and miscarriages. Here's a good practice pearl. Ask that as a combined question. If you ask somebody, particularly if their significant other is there, they may not be honest with you on if they had any abortions. But for us, this is just our risk assessment. We want to know how many times that cervix has been pried open and closed, because that's leading us to know what our risk is that this patient's going to deliver. So I frequently will ask together, how many abortions or miscarriages have you had? And then the last dash is now living. So for example, EMS calls and they say that we've got a patient that's G12, she's been pregnant 12 times, para 3. Well, what does that mean? So all of those in between dashes, term, preterm, abortions, and now living, so we use the acronym of TPAL, that's what's going to be telling you your obstetric history. So for example, if this patient was pregnant 12 times and 5 of those were preterm deliveries, and she delivered at 24 weeks, because she had a broken bag and none of those babies survived, that's significant. Particularly if the EMS over the tele radio is telling you, oh yeah, guess what? She's 23 weeks, she's contracting and her bag of water's broken. So that inside information of answering that TPAL is gonna tell you how much pucker you should have with this patient coming in. So it's really important that you're having the paramedics ask how many term, how many preterm, how many abortions and miscarriages, and how many now living. Okay, so the next thing we want to know is when was the date, if she's a multip, of her last delivery. So for example, her last baby, maybe she's got a new significant other, her last delivery may have been 12 years ago. Well, technically she's a multip, but that's been a long time and her uterus might have kind of forgotten what to do. Now, the opposite could be she just had a baby 14 months ago. Right? That uterus is like, dude, been here, done that, got that t-shirt, Cletus the fetus, you're out. So that patient is going to have a faster labor and typically a faster delivery. So the other thing you want to ask EMS over the tele radio is, what was the duration of her last labor? So certainly significant. If her last labor was, 36 hours or 24 hours, and she's in with her second baby and her contractions are kind of irregular, you can have less pucker. If her last delivery was 3 hours from start to finish, it was a year ago, and she's been home laboring for the last 6 hours, that's going to certainly increase the amount of pucker that you have. Next thing you want to ask paramedics or the patient coming in is, how regular are those contractions? So for example, if a patient is contracting 2 minutes, 5 minutes, 7 minutes, 17 minutes, 4 minutes, 6 minutes, those contractions aren't regular. She may be contracting, maybe she's been doing this for the last day, but it's less effective and the cervix doesn't normally dilate with irregular contractions. Now, patients that are contracting with regularity. So you can have a multip, remember, been there, done that, got that t-shirt, and her contractions can be every 9 minutes or every 10 minutes. But because she's been doing this for the last couple hours, that's regularity, she's more likely to deliver on you. So again, TV makes everybody think, okay, the patient's contracting every 3 minutes, there's a commercial break and the babies fall out. So not necessarily, but knowing how regular those contractions are and how long they've been contracting helps you to assess your risk on this patient delivering on you. Okay, so again, the labor pain can also be subjective because some patients are going to have a higher pain tolerance than others. Also, if patients are afraid or if they have secondary gains. Thank God they're not male. I mean, guys, not that I'm underestimating the man flu, because that is a real thing. I mean, people die from the man flu, mostly because women like me want to kill you, but it is a real thing. Okay, so other things we want to ask over the tele radio, I know you don't have a long time, is that bag of water intact? So again, just because the bag of water is intact doesn't mean she's not going to deliver on you, but patients with broken bags tend to labor, their contractions are more regular and they tend to be stronger and they tend to be more players. So again, hopefully your bag of waters did not break at the grocery store or at Target. Clean up on aisle 6, that could take on a whole new meaning, right? Last thing we want to know is, has she had any complications with this pregnancy or last pregnancy? Pregnant women tend to be recidivist. If they did it wrong the last time, they're going to do it wrong this time. So for example, preterm labor. If a patient had preterm labor with her last pregnancy, she's more likely to have preterm labor with this one. Okay, so calling Dr. Stork. So again, this is specific to the University of Chicago. So in the Comer ED, you get a call over the teleradio. You've got this prego my ego patient coming in. I'm not 100% clear on when you call Dr. Stork, if that is protocol or algorithm driven, but all of us have had very bad things happen to us because we stuck to the rules. So what am I going to tell you at the risk of getting in trouble by somebody who wrote that algorithm? That you need to follow your gestalt. So if the hair is standing up on the back of your neck and you want to invite other people to this birthday party, namely labor and delivery in the NICU, then you should call Dr. Stork. Do you have to wait until that patient hits the ED, or can you call when that patient is still en route? If you're asking me, and you're concerned about this patient, call when that patient is en route. I mean, the very worst thing that's gonna happen is the Dr. Stork team is gonna get there and you're gonna be like, hey, I don't need you. But I think it's really important that I'm empowering you guys to follow that gut feeling, because most of the time it's right. And again, worst thing that's gonna happen is we're not gonna need them, so we're sorry, not so sorry. So again, remember, for when labor and delivery in the NICU get that call, they rarely have somebody waiting at the elevator with the Dr. Stork kit. Like, they have to hand off their patients. They have to tell somebody where they're going. So it's better to give them more time than less time. So now for my transport peers, other people that do interfacility transport. So when we're transporting patients from one hospital to another, we want to know what their current cervical exam. And let me tell you, the docs lie when the truth sounds better. No offense, docs, but they're trying to get this patient out of their hospital and make this patient somebody else's problem. So they're going to say, trust me, she's 2 centimeters. It's kind of like, for my ED people, it's like 2 beers. I had 2 beers. So remember, that's, you know, usually a multiplication of. So another thing that can happen is they can tell you that the patient is not dilated, but they'll say that she's got lower uterine segment pressure. So I don't know if you can see the arrow here, but this lower part of this light bulb looking thing, which is the uterus, that's the lower uterine segment. And as that presenting part is there, be it butt or head or whatever that presenting part is, it's going to put pressure on this lower uterine segment, and it's going to cause that cervix to dilate. So what about patient reliability as far as the amount of pain or the contractions that they're having? Well, the good thing about OB patients is they're reliable historians, right? Like, they can tell you, I'm allergic to this and this bad thing happened to me and my baby fell out last time. They're pretty reliable with their history. The problem is, the more preterm the patient is, the smaller that uterus is in gestation, the less pain receptors are activated by contraction. So we need a more gravid uterus for the patients to actually perceive the contractions. So preterm, it's very, very common that if you ask your patient, hey, are you contracting? They'll deny it because she doesn't feel what she has either felt before with contractions or what she thinks contractions feel like. Commonly, the preterm patients, they're going to complain of a backache. They're going to complain of UTI symptoms. They're going to complain of kind of this colicky, cramping kind of pain. They might also say that they feel like they might have the flu. They feel kind of like diarrhea. It's that cramping kind of pain. The most common description of preterm labor by patients with little teeny tiny cletus the fetus is they say they feel like the baby is balling up. So they don't realize what they're feeling is a tightening of the uterus. In their mind, they feel like the baby is kind of crunching up inside of them. So next time you have a patient that has pre-gestation and she says she's not contracting, ask her, do you feel like you have a backache? Do you feel like you have a bladder infection? Do you feel like the baby's balling up? And oftentimes they're going to say yes. So the next question is, should I stay or should I go? Is this patient going to be delivering in the ED, or do I have time to get this patient up to labor and delivery? So part of that is going to be a subjective and an objective evaluation for us. So first thing that we want to do is we want to palpate and see, is this patient contracting? So up here on the very top of the uterus, between these blue arrows, is the fundus, or the top of the uterus. That is where all contractions start. Even if the patient is only feeling back pain or only feeling pain over her bladder, it doesn't matter. We will palpate the contractions the easiest on the fundus. So on the very top of the uterus, that's where we're going to palpate. And remember, you have to kind of push down through the patient's subcutaneous layer. Some patients are skinny mini and they're really easy to palpate contractions, and other patients are more fluffy. You know, they might have a bigger body habitus, right? So if your patient looks like Jabba the Hutt, it's going to be harder for you to palpate those contractions. But the contractions start at the top. They have a wave-like activity as they reach the cervix, and they diminish in strength. So that's why we're always palpating them on top of the uterus or at the fundus. So again, when patients have that spontaneous rupture of membranes, which is what SROM stands for, it's not always clear. So if it's a gross rupture of membrane, you know, where that water bag got stabbed, kaplooey, that's going to be a large gush of fluid. That's going to be easy for our patients to tell. However, if our patients have what we call a high leak, which is kind of like a pinprick or a little bit of a hole in that bag of water, then they just have this intermittent trickling, and that's harder to tell. I mean, let's face it, pregnancy is super glamorous. It's not uncommon to be ooey and gooey in the vaginal area. So you've got cletus, the fetus, bouncing on your bladder. You've got increased cervical mucus, trying to keep bacteria out of the uterine environment, and or you could have a ruptured bag of water. So it's harder for them to tell. So I always ask my patients when they come in, are you feeling any leaking? Have your underpants been wet? And then after I know the answer to that question, then I can go down my algorithm. Is it amniotic fluid or is it urine? So most of the time in the ED, we do not carry nitrazine paper like they have up in labor and delivery, but we do. So if you're really curious, the paper that's inside of an end cap is nitrazine paper, so you can use that. So in the presence of amniotic fluid, nitrazine paper will turn a very vibrant royal blue. Okay, so the other thing that we want to know is, what is that fetal size and gestation? So for example, if I have a really preterm baby like this, I mean, this is probably maybe a 19 or 20 weeker, right? That patient doesn't have to be 10 centimeters dilated in order for her to deliver a fetus that is this small. So knowing how long she's been contracting, how fast her last labor was, if she's already had a baby, what her pain is, and what that gestation is, going to help you make that decision. Do I stay or do I go? So here's a little quiz for you. What OB patients are considered to be high risk? So if I'm asking anybody but labor and delivery, the answer is going to be all of them. And my next question is, what is the primary treatment of all high risk OB patients? Again, the proper use of the elevator keys, for real. But none of us want to be in the elevator delivering Cletus the fetus. So how are we going to know if this patient's ready to deliver? So first of all, we're looking for imminent signs. Does she have regularity of those contractions? Remember, the patients that are contracting with regularity, we time contractions from the beginning of one contraction to the beginning of the next. Lay people don't do that. Lay people time their contractions from the end of one to the beginning of one. So again, when a patient comes in and says, I'm contracting every 1 minute, that's not possible. We time ours from the beginning of one to the beginning of the next. The next thing is they may present with bloody show. So bloody show is different than vaginal bleeding. So vaginal bleeding normally will be dark, or it can be bright red depending on if it's a previa or an abruption, but it's typically clotted. Bloody show is like bloody snot. Let's be super glamorous here. So the cervix during the pregnancy gets this thick hunk of cervical mucus that covers the cervix because it's protective. The vagina, you might not know this, is a self-cleaning oven. Who knew? So there is bacteria and flora that live inside the vagina. They live in the vajayjay, the lady garden, if you will. And they keep that bacteria and that flora in its normal ratios, the way it's supposed to be. However, the uterine environment is sterile. So we don't want that bacteria and flora that normally live in the vagina to ascend into the cervix. So one of Mother Nature's fail-proof plans is to put that thick, sticky mucus over the cervix. So before these patients go into labor, or sometimes during labor, these patients will pass this cervical plug. That is not a definite sign that your patient is in labor. Sometimes these patients can lose that cervical plug a couple of weeks before they go into labor. So one definite imminent sign is when your patient is doing what I call the poop scoot. So they're laying on EMS's cot, they're clenching their butt cheeks together, usually holding their breath, and they're kind of scooting up the back of the cot. And when you ask them what's wrong, they're going to tell you, oh, I gotta poop, I gotta poop, I gotta poop. Okay, if you ever hear a pregnant patient say that they have to poop, put on gloves, put on eye protection. A baby is coming until proven otherwise. So why is that? Okay, so if you look at this picture here, again, the cletus, the fetus, his presenting part is coming down. He's putting pressure on that lower uterine segment. This is the cervix here. And you can see with the direction of his head as it's moving forward, it puts pressure on the bowel and on the rectum. Now, this is Mother Nature's way of when that cervix is completely dilated. The muscles you use to have a poop are the very same muscles you use to push out a baby. Again, I cannot make this shit up, literally, all very glamorous. So again, when your pregnant patient says that they have to poop, you need to assume that it's the baby's head. So make sure you put on gloves. So the other thing with patients that are imminently delivering is they involuntarily will be pushing. And we can't help it. We're always going to say, don't push, don't push, don't push. Do a breathing pattern. And your patients are going to respond with, I'm not pushing, because they can't help it, because they feel that pressure of the baby's presenting part on that bowel and on the rectum, and it's just too strong of an urge. So they're sorry, but they can't really help themselves. So the other thing that we look for is the anus dilates. Again, like, I should have told you to bring popcorn and a beer to this lecture. It's so much fun, right? So yeah, you look and that anus will start to dilate. And again, it's because of the baby's presenting part that's pushing on the anus and causing it to dilate. So I'm going to tell you guys a super funny story. When I worked in labor and delivery, I don't know why, but we would call that anal dilatation rosebudding. I don't know why. It doesn't look like a rosebud. It does not smell like a rosebud, but that's what we would call it. So it was good for us because we knew our patient was getting closer to deliver. So I was pushing with this patient. She was a primate. Remember, the same muscles you use to have a poop are the muscles you use to push out a baby. So she's pushing, 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 and they do sometimes poop a little bit, but we never tell them, because if we tell them, they're going to be embarrassed, they're going to stop pushing, and then I don't get to go to lunch. So we never tell them. So we just change the blue Chucks pads that are underneath them. So I'm pushing with this prime-up. You know, for most normal human beings, it takes an hour to 2 hours to push out your first baby. So I'm pushing with her. She is pooping a little bit. I don't realize the dad comes around my shoulder and he looks and he sees this dilated anus and he sees a little poop turtling out. And he goes, honey, the baby's got brown hair. So hopefully that will not happen to you. So remember, the patient's anus will be dilated, but ours will not. We will have super clenched because we have no intentions of delivering this baby. So the other sign of imminent delivery is crowning. So again, slapping her knees together, using silk tape, covering up the evidence is not going to stop that baby from coming out. So certainly this is a delicious crowning. I got strawberry here, and I get this. The chocolate sprinkles as the pubic hair, super clever. My question is, look down here at the rectum. Does that mean she's got hair coming out of her ass? I'm not quite sure what that means, but I find it very disturbing. And I want you to know I've never been able to eat chocolate sprinkles since then. Okay, your number one positive confirmation that this patient is going to deliver is she's going to tell you. She's going to tell you the baby's coming, the baby's coming, the baby's coming, even if the doc just did a vaginal exam and said she's not dilated or not dilated very much. Doesn't matter. Women lie about a lot of things, but they do not lie when they tell you that the baby's coming. So what are some of our emergency department or pre-hospital or transport considerations? So first consideration is you have to consider your hospital resources. So again, if I'm talking about the University of Chicago, we're pretty lucky, right? We can call a Dr. Stork and we can hear the pitter patter of labor and delivery and the NICU that are coming to help us, but not every hospital has that as a resource. In fact, some hospitals don't even have OB services. So again, your place or mine, that is going to be the $60,000 question. Are you delivering the patient in the emergency department, or do you have time to get that patient up to labor and delivery? If you have made that clinical decision that the patient needs to be delivered in the ED, then who are you inviting to the birthday party? So of course, we want everybody to come to the birthday party, but again, it's going to depend on your hospital resources. Next thing that you need to do is rock, paper, scissors. Who's got mom and who's got baby? So again, a lot of the ED people or the pediatric ED people, first of all, they did not sign up to take care of adult people, and they did not sign up to take care of pregnant people. They may think, I'd rather take the baby, but that's not necessarily an easy answer either if you've got a 24-weeker that's popping out. So let's go over normal spontaneous vaginal delivery. So if you have a patient that is not literally squishing the kid out, but it is going to be an imminent delivery, we try to put a pelvic tilt underneath the mom's pelvis, because that's going to help us with our maneuvers when we're delivering this baby and make it more likely that her perineum will be intact and that she won't have a laceration. So most precipitously born babies are occiput anterior. That means the top of their head is facing up. So if I'm the labia here, the baby is looking down at the ground. And most of them are in that position because that's how they fit through the key and the lock the easiest. So our hand position, we're going to put one hand over the rectum, over the perineum, and the other hand is going to be over the baby's head, not stopping that baby from coming out, but just controlling that rate of descent. So we're going to check for a nuchal cord. Now, in this example, I've got 3 loops of nuchal cord. So let me talk to you about nuchal cords. First of all, they're pretty common. About a third of the time, babies are born with a cord around their neck. It's unusual that it's wrapped 3 times, but if it's wrapped more than 1 time, which loop of cord do you clamp and which do you cut? It doesn't matter. Just make sure that you're clamping on the same loop of cord, then you cut in between and you simply unwrap like you're playing jump rope, okay? Now, if it's a nuchal cord and it's loose, you can simply just slide it over the baby's head. If it's tight, then you're gonna need either 2 surgical clamps or 2 yellow cord clamps and then cut in between. Let me give you a fair warning. Your hands are going to be doing this. Your hands are going to be wet. Those suckers are going to go flying across the room. It's kind of like, your ice cream. It's the 3-second rule. Just pick it up. It's fine. This is not a sterile procedure. Just put the cord clamp on and you can use it, unless you've got clean ones available. Okay, suctioning the mouth and nose. So this is kind of old school. We don't really do this anymore. When the babies come out, if they need to be suctioned, we suction them, but we don't hold them on the perineum to suction them anymore. Okay, so once the baby's head is out, the shoulders, even though the head is the widest diameter, the shoulders are going to be too wide in this plane or this diameter. So the baby needs to make a rotation and the shoulders need to shimmy in order to come out. So we're going to deliver the anterior shoulder first, and we do that by putting our hands over the baby's ears. And you can see how the fingers are kind of open like this and over the baby's shoulders like that, so we can keep the baby's head in alignment. We're just gonna do some very gentle traction down. Basically what I tell people is bend your knees, just bend your knees, and it'll pop that anterior shoulder. And then we're gonna gently lift up to deliver that posterior shoulder, but I gotta warn you, once that posterior shoulder is delivered, you're gonna get an armful of baby. So I always, when I'm teaching EMS, I say expect a loud cry. That may be you, that may be your partner, but hopefully it's the baby. Okay, and here's a video. I made this for school, so it's a little janky, but just stick with me. And here we go. Good afternoon, everybody. Thank you so much for attending this educational program. My name is Terry Campbell. The topic that we're going to cover today is emergency vaginal delivery. So let's jump into the psychomotor skill. So of course, I'm going to put my hair in the emergency ponytail holder. I'm going to make sure that we have appropriate BSI, because one of the #1 rules in emergency medicine and EMS is if it's wet and not yours,
don't touch it.
Exactly. Okay. So the very first step is going to be hand placement. So I'm going to put my, oh, excuse me, I did not introduce my primary actress. This is Vagina Lokia, and this is Cletus the fetus. So very first step, my hand is going to be over the perineum like this, applying some counter pressure so it doesn't tear. As the baby's head is crowning, my hand is gently placing here, not to stop the delivery, but to slow the descent. Baby's head is going to be delivered. I now go to the second step, which is checking for the nuchal cord. In this demonstration, it's going to be uncomplicated, so we're not going to have a cord. If we did, I would simply slide it over the baby's head. If it was too tight, I could use 2 surgical clamps like this, or 2 umbilical cord clamps like this, and then I would cut in the center with a surgical scissors. Now, when the baby's head is out, the head is the widest diameter for most neonates, but in this plane and in this position, the baby's shoulders are actually too wide to fit through the pelvic bones. Think of the baby fitting through like a key into a lock. So the baby, the third step is the baby is going to make an internal rotation like this. Now you can see my hand placement is over the baby's ears and over the baby's shoulders. My fourth step, I'm going to apply gentle traction down. I'm going to deliver that anterior shoulder. My fifth step is I'm going to gently lift up and deliver the posterior shoulder, but I have to warn you, as soon as you do that, you're going to get an armful of baby, which is the sixth step, which is pulling the baby into you. Fifth step, deliver up, and then sixth step, pull the baby into yourself like this. Now, to quickly review the 6 steps, first step is going to be hand position over the perineum and on the crown. Second step, checking for that nuchal cord. Third step, assisting with that internal rotation. Fourth step, gentle traction down to deliver the anterior shoulder. Fifth step, gentle pressure up to deliver the posterior shoulder. Sixth step, pulling the baby into you. Now, are there any questions? Okay, so let's go on. Okay, so baby's out. Now what do you do? So once the baby's out, we want to leave the baby either at the level of the perineum or on the mom's chest, because until that umbilical cord has spasm, there's still going to be communication between the placenta and the baby. So anybody who does not know what a beer bong is, then I'm sorry, we can't be friends. But again, once that baby is delivered, if I lift that baby up in the air, you know, because I'm doing my best Lion King impersonation, that blood from the baby can communicate and go into the placenta, and I'm going to end up with a hypoperfused baby and me doing NRP, which is a bad day. The same thing if I'm delivering the baby and I drop the baby very low, then the baby can get a gush of blood from the placenta. So in labor and delivery, and what we do now is something that's called delayed cord clamping, because this is really beneficial for our baby. It gives that baby some extra blood volume from the placenta, and it really helps our kiddos out. The great thing is in the pre-hospital or in the pre-labor and delivery areas, such as the ED or the pediatric ED, we're not in a big hurry to cut the cord. So just let that baby be delivered and put that baby to mom's chest. Naked baby to naked mom is the best thing to keep that baby warm. So again, don't rush to cut that cord. So our neonatal concerns. So remember, this kiddo came from an environment that was a minimum of 98.6. And if we're lucky, is coming out to an environment that's in the 70s, right? So they can get very cold very quickly. They're wet. So dry them off with whatever you have available. A towel, a blanket, your partner's t-shirt, I don't really care. Here's the trick though, you have to change that wet blanket and that wet towel and make sure that they have something dry. Think of it as getting out of the shower and your partner used the towel and now you're using a soaking wet towel. Remember how that like hacks you off? Same thing for our babies. So again, best way to keep baby warm, dried head and naked baby to naked mama. If the baby is going to be in the ED, it's important to do an AccuCheck. It's a little bit beyond the scope of this lecture to determine if this baby is appropriate for gestational age or small or large, but do an AccuCheck. The other thing that we really encourage is putting the babies to breast, even if moms are not breastfeeding. First of all, it's going to prevent hypoglycemia with cletus the fetus. It's going to help with separation of that placenta, and it's going to minimize the risk of mom having a postpartum hemorrhage. Okay, so let's talk about precipitous deliveries. So precipitous deliveries are exactly like I just demonstrated in the video. It's just a heck of a lot faster. These kids are literally catapulted out of the uterus. The bigger problem that we have is more so for mom, because her poor perineum doesn't have time to stretch and kind of grow and accommodate, and often she can have some lacerations. So this is what we call a 4th degree laceration. So again, I'm going to try to orient you to this picture. So up on the patient's laying a little cattywampus here. So up on top here is the clitoris. Down here at the very bottom is the anus or the rectum. So this is what we call a 4th degree laceration, or what one of my paramedic friends calls a vaginus. Yes, she now has a vaginus. Now, again, I reminded you of how I teach. So just as a public service announcement for anybody who identifies as having female parts, okay, no matter what their gender is, if they identify this way, I would just like to offer a quick little PSA. So up here on top, this is the clitoris. This is the clitoris. Not over here, not over here. It is clearly not here. It is up here. This is the clitoris. Okay, there you go. People that identify with female parts, you're welcome. Okay, all right, let's go on. So again, we want to avoid the vaginus, and that's why we're putting that other hand on the perineum, kind of offering that counter pressure to prevent that from happening. So the other problem that we have with our precipitous deliveries is cletus the fetus literally comes out. You'll see this baby lying on the cot, kind of blinking his eyes and not breathing. So again, time spent through the birth canal is compressing that chest, kind of expressing some of that amniotic fluid that's in the lungs. And these babies come out so fast, they don't have time for that fluid to be expressed out of their chest. Also, they're kind of stunned. So once we dry them off and start stimulating them, they usually start breathing right away. You might have to do a little bit of BVM, but most of the time, just drying them off will stimulate them to breathe. I'm sorry, to breathe. The other thing that you're going to see is that these babies often will have bruising on their face and on their head. So if we look at this baby here, if this baby was all wrapped up, you'd be like, ah! You know, is this baby a congenital heart? Is this baby hypoxic? Why is this baby blue? So again, I don't know if you can see my little arrow, but if we see here under the baby's chin, we can see that this baby's chest is nice and pink. This baby is not in any distress, but that is a big old bruise from a precipitous delivery. It's kind of hard to not say, does your face hurt? because it's definitely killing me. Okay, so next one we're going to talk about are breech deliveries. These are less common, only about 3 to 4% of all deliveries, and often it's because they're premature or there's multiple gestations. Most babies are head down, not because they're smart, not because they follow the exit sign, not because they're following the light. It's because the noggin is the heaviest thing, and gravity sucks most babies down to a vertex position. So again, if you've got a baby that's preemie, the head might not be heavy enough and that baby might not be down in that vertex position. So again, with multiples, you know, you've got all those like puppies laying in there, head to tail and laying over everybody. And so it's rare that they're all going to be in a vertex position. So if you're assessing fetal heart tones, your clue is that the fetal heart tones are going to be above the umbilicus. Because remember, if the head is up here and on top with the fundus, and the back is either this way or this way, we're going to be hearing heart tones up on top. Babies that are vertex or head down, we tend to hear the fetal heart tones below the umbilicus. Okay, another clue is if this patient's bag of water is broken, there will be very thick, very particulate meconium. So if a baby is breech butt first and the baby poops, there's very little amniotic fluid to thin it out, so it comes out very thick and very sticky. If the baby is vertex and poops up, by the time that meconium comes out, it's going to be kind of liquefied with other amniotic fluid, and it tends to be more thin. So when I was working in labor and delivery, I had a resident that kept examining this patient, kept doing exams and saying, she's 1 centimeter, she's 1 centimeter, she's 1 centimeter. And I could not figure it out because it was a multip, like she should have been advancing, her cervix should have been dilating. So Randy came out of the room and he had really thick meconium like this on his glove. And he's like, oh my gosh, Terry, I'm really worried. Look at how thick this meconium is. I went in and examined the patient. The patient was completely dilated, but she was breached. So guess what Randy was doing? He kept putting his finger in the baby's rectum. 1 centimeter, 1 centimeter, 1 centimeter. And finally the kid was like, and pooped on him. Can't say as I blame him. Okay, so what are the presentations that these kids can have for breech presentation? So frank presentation, which is the one all the way over to the right, that's the most common. They're in kind of that folded or that pike presentation, and that's just the easiest way that they fit out. The complete breech is the one that's on the far left. That's kind of what I call our cannonball position. So you jump into the pool and you yell cannonball. And then the next position is the footling position. So here's the good news. Footling position, you guys are not going to deliver in the ED because those kids do not come out easy. Those kids are doing the splits, one leg's up, one leg's down, and they just do not fit through the bones of the pelvis. Most of the time, these kids are delivered by a cesarean. The concern that you have to have for the incomplete and the complete breech is the risk of cord prolapse. Because with a vertex delivery, the head is going to be occluding the cervix. Or in a frank breech position, the tushy is going to be occluding that cervix. With the footling or the double footling breech, which are slings, you don't have that nice tight closure over that cervix, and the umbilical cord can slip out. So this is a little baby that was born in a frank breech position. So when they come out, they are super cute because this is how they've been laying in the uterus for the last 9 months. So this is how they prefer to lie. We dry them off, we change the blanket, their legs go down. It's not like they've got contractures and they're stuck that way. But remember, that's how he or she is comfortable. So those legs, whoop, are gonna go right back over the head. And of course, like the nurses love it because they just look so cute. The only one who doesn't like it are the dads of the little girls. Somehow this makes them very uncomfortable that their daughter is lying in this position. Now, I'm always very reassuring and I say, don't worry, as soon as her hip flexors relax, her legs are gonna go down, she'll be in more of a normal lie, and she won't be in that position again for at least another 15 or 16 years. Okay. All right, so how are we going to be delivering these kids? Here's the good news. Keep y'all hands to yourself. That's how we're going to be delivering these. Absolutely no pulling. These babies are going to spontaneously deliver up to the umbilicus or up to the scapula. So if the baby is in that pike position, which most of the time they are when they're delivering precipitously, you don't even need to reduce their legs unless they kind of get stalled or stuck. They can deliver that way. If they're kind of stuck, you can kind of push your finger behind their knee and it'll cause that leg to bend, and then you can just grab their little foot and extend it. I'll show you on the video. And again, remember when these babies come out, they have to rotate. So the babies do these cardinal movements, but they do them inside the uterus and inside the pelvis when they're vertex and we don't see them. So when they're breech, we see these maneuvers that they have to do. So as that baby comes the shoulders, remember the shoulders have to shimmy. We're going to deliver the posterior shoulder first and then the anterior shoulder. So now the baby has to make another rotation so the baby's head is down, occiput anterior, because again, that's how they're going to fit out the easiest way. Our temptation is to pull because we've got this baby. But if I pull, when babies are born, their heads need to be in a flexed position to fit through the bones of the pelvis. If I pull the baby, I'm going to force that baby to be in an extended position, and the baby's head is not going to fit through the pelvis. So when we get to this point, we're going to force that baby to be in a flexed position by doing a maneuver like this. It's called morceau smelling. So my fingers, I'm going to insert vaginally on the back of the baby's neck, head on the occiput, and I'm pushing it forward. My other fingers are going to be inserting vaginally under the baby's zygomatic bones, and I'm pushing down. So again, forcing that baby in a flexed position, and it looks like that. Okay, we don't want to put our fingers in the baby's mouth and pull the jaw down. That used to be an old way that the docs used to do it, but the problem is you can dislocate the jaw. Okay, then we're going to do the J-loop flip and put the baby on mom's tummy. So let me show you what this looks like. Okay, breech delivery. Breech delivery is going to be a little bit more tricky. So that little tushy is going to be coming down. Push, push. Okay, now with the breech delivery, hands off. So we're just going to let that baby come out up to about the umbilicus. So Kyle, the uterus, is going to continue to push. Great job. And this is the hardest part, is doing hands off. So we're at the umbilicus. Jean now is going to be able to push behind the knee, kind of flex that knee, get that foot to bend. Okay, Kyle, push a little bit more. And then she's able to pull that leg down. So we'll do the other side, bend that knee, grab the foot, pull it down. Now, again, we're letting gravity pull this baby down, but this baby's gonna get cold. So this is where we would use a dry towel to dry off the baby. Jean's hands then are gonna wrap around the baby and her thumbs are gonna be on the sacrum, but she's not pulling. Baby's gonna come down to about the scapula. Now Jean is going to need to get those arms. So she's going to reach in, and the arms are actually going to sweep in front of the baby like this, because it's going to be able to make that diameter more narrow than if the arms are up like this. So she's doing a great job. Okay. Now, remember, just like for our vertex delivery, the baby has to be lying in a rotation to deliver those shoulders. So now the baby's going to rotate. Now, this is a little bit trickier because we're delivering the posterior shoulder first. So Jean is going to gently lift up to deliver that posterior shoulder, gently down to deliver the anterior shoulder. Now, remember, the baby needs to be in that occiput anterior. Baby's going to make another rotation. This is honestly the scariest part because we don't know if the head is going to fit through. We're going to be moving mom's legs back as far as possible because it's going to open up that pelvic outlet. So Jean's going to use her arm to support the weight of the baby, and she's going to do something called the morceau maneuver, where she's pushing in on the back of the head, flexing that baby forward, the other two fingers on the zygomatic bone,
forcing that baby into flexion. She's gonna do a J hook and flip that baby on top of mom. Voila. Cut.
Okay, so what are some of our breech pearls? So if you have a patient that's delivering breech and has the ability to pee, have her pee. That bladder gets big and puffy and in the way, and we're gonna need as much room in there as possible for this baby to come out. Also, as I mentioned in the video, as these kids are hanging outside of the uterus, remember it was 98.6, it's now considerably colder. So dry that baby off, get rid of that wet blanket, and wrap that baby with another dry towel. Then put your hands on the baby's sacrum without pulling. Consider an episiotomy. So again, I realize the ED nurses are like, say what? But if the docs are there and they need to get their hands in to help do some of those maneuvers, it's going to be easier if there's a little bit of an episiotomy. Again, it's going to depend on your patient's anatomy and how big the fetus is, right? So again, I had mentioned with breech that the complete or the footling breech will have a higher risk of having a cord prolapse. So unfortunately, if there's a cord prolapse, you have to do a vaginal exam, run into that presenting part and lift up. I call it the Statue of Liberty move. I have to give you a fair warning, your arm is gonna lose feeling, right? Because you're holding it up there for so long, you almost get a paresthesia. So here's a video on what to do with cord prolapse.
Okay, guys, last thing that we're going to talk about is the umbilical cord, the prolapsed umbilical cord. So as this cord is hanging out and that baby's presenting part, either head or tush, are compressing on that cord, it's kind of like an astronaut cutting off their lifeline. So what Gina's going to do is Gina's going to do a vaginal exam until she runs into something hard, be it head or butt, and she's going to push up. Now, if she were to stand here and hold this, her poor arm is going to be shaking because that's a lot of weight to be supporting. Because remember, she's going to have to keep doing this all the way until she goes up to labor and delivery, until they go into the delivery room, and until the baby delivers. So an easier way to do it is exactly what Jean is doing. She's using a towel or a blanket here under her elbow so she can use that as a fulcrum to support the weight of the baby. Because remember, she's probably going to have to hop on the cot and go up to labor and delivery with the mom. So that's how we're going to hold up an umbilical cord prolapse.
Okay, shoulder dystocia. So again, shoulder dystocia, the benefits that we have here is that the OB people will probably be here because this isn't a kid that falls out. But with the shoulder dystocia, these are bigger kids, usually large for gestational age. And although I told you that the head was the widest diameter on most kids, with the shoulder dystocia kids, the shoulders are bigger, not the bones, not the bony skeleton, but the fat padding that's on top of them. It's kind of like a baby wearing football pads. Okay, so you can see in this picture here, this white bone here is a symphysis pubis, and the baby's shoulder is getting stuck under this. It needs to go under that bridge of the symphysis pubis. So again, most of these are El Grande Niños. They're big babies. It may be a baby that's born to a diabetic mom. It could just be a big old kid, big old baby. So one of the things that we look for, that we don't look for, we kind of panic when we see it, is something that's called turtling. So what happens with turtling is the baby's head will come down, and then in between contractions, it goes back in. And then it comes back out, and then it comes back in. So what's happening is, as that mom is pushing, the baby's neck is actually extending. And then in between the contraction, it's coming back down, because remember, the shoulders are unable to get underneath that bone. So it's just extension of the neck that you're seeing. So the other thing that you're going to see is a very purple baby face, which is terrifying for everybody in the room. So when you see kind of that turtling, or you see that very purple face, it's really important we get that mom's knees back as far as possible. So we call it McRoberts position. So McRoberts position is that patient is laying a little bit semi-Fowler's, meaning her head's up a little bit. She's got her hands behind her knees on her thighs, pulling her legs back as far as possible, or more commonly, we've got our hand on her foot and we're shoving her knees all the way up by her ears. Now, let me give you some fair warning. Women are going to say, I can't get in that position. I promise you they can get in that position. The reason that we want it is if we look at this picture on the left with her legs down, you can see how narrow this pelvic opening is. When her legs are back, it greatly opens up this pelvic opening. And right here is that symphysis pubis that we're trying to get underneath. So again, she's yelling she can't get in that position. You're shoving her feet, getting her knees back by her ears. The hard part is, again, inside voice, because I know exactly what you're thinking. You're like, I'm sure you've been in this position before, right? Maybe that's what got you here to begin with. Okay, so the benefit of McRoberts' position is this position alone is going to resolve about 50 to 90% of shoulder dystocia, so you're going to be able to deliver that baby. If McRoberts' position doesn't work, we're going to have to do some suprapubic pressure. So you can see on this video, on this picture here, this tendon's hand, or like palm, the heel of the palm, is pushing straight down over the bladder, over that suprapubic area. And what they're trying to do is shove that baby's shoulder down while the mom is pushing to get under that symphysis pubis. You do not want to push up here on the fundus or the top of the uterus. First of all you're doing is running that baby's shoulder into the symphysis pubis. You're not getting it underneath it. Second of all, the fundus is the most narrow, or is the thinnest part of the uterus, and you could cause a uterine rupture. So we don't want to do that. We're never pushing on the fundus, only applying that pressure over the bladder. So think of it like bladder CPR. As mom is pushing, you're just holding that pressure down for about 30 to 60 seconds. If that doesn't work, then you're going to do it a little bit like bladder CPR. So let me go back to that. So the other thing we don't want to do is we don't want to do head traction. We don't want to grab onto that baby's head and start pulling. Certainly mama had a baby and his head popped off. We don't want anything like that to happen. Right? So again, if for that next contraction, that 30 to 60 seconds wasn't enough to relieve that dystocia, then what you're going to do is you're going to put your arms straight out in front of you, just like you're doing CPR, over mom's bladder. So you need to be above her, usually on a step stool, and you're compressing on her bladder as she's pushing, and you're rocking that shoulder under the symphysis pubis. Okay, other maneuvers that I'm just going to quickly go over, because I don't expect you to do these, but the OB people will do them. So what they're going to do is they're going to take two fingers, one on the anterior shoulder and one on the posterior shoulder, and they're trying to maneuver that baby to get into that lateral position so the baby can shimmy. Because oftentimes what happens is the baby gets caught in kind of this asynclitic plane instead of being like this. And the other thing that I do want to give you fair warning of is that, you know, the labor and delivery people that show up, they may have never delivered a breech baby before, because often for breech deliveries, we're delivering these patients by cesarean. So they may not be much more experienced than you are. So you may be able to offer them some clues. So another maneuver is similar to the one that I just described, which was Rubens, which is just flipping your fingers and trying to flip the baby's shoulders in another direction. Okay, other tricks we can do. This is a great midwife's trick. Put the patient in all fours. By putting the patient in all fours, it's going to help to open up that pelvic outlet and make some more room to deliver that baby. Again, make sure she's got an empty bladder. Consider an episiotomy. Again, an episiotomy doesn't make more room for bony structures, but it makes more room for us to get our fingers in there to help manipulate those baby's shoulders. This is a little acronym. Put the patient in McRoberts, deliver the anterior, posterior shoulder, and salvage maneuvers, or what I like to say, shite your pants, which is hopefully not what we're going to do. So last ditch, if we have a baby that is a shoulder dystocia that we can't get out, and remember, we're in the ED or the PEDS ED, so it's not like we have an OR open across the hallway. What the OB clinicians can do is they can fracture the baby's clavicle. Now, breathe, 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 breathe. It's okay. Babies get fractured clavicles sometimes spontaneously in delivery. And it's super easy. We don't put a figure of 8 on them. We don't cast them. All we do is when we put them in their t-shirt, we just safety pin their arms on their t-shirt like this. The clavicles are going to line up perfectly. They're going to heal and they're going to be fine. It's way better than having a baby that's neurologically devastated because we can't get this baby out. If fracturing one clavicle doesn't work, we fracture the other clavicle as well. I know you're pooping yourselves right now, but you will not be alone for that. The very last option is something that's called the Zavanelli maneuver. Before I tell you about this, I have personally delivered over 5,000 kids. I have seen this once. So with the Zavanelli maneuver, if we can't get the baby out vaginally, we have to shove the baby back in and do an emergency cesarean delivery. So the one case of this that I did see did not have a good fetal outcome. Ooh, that was a rough way to end this lecture. So in conclusion, in the emergency department or in the pre-hospital world, we have to have a risk assessment. Like, is this patient going to deliver in our house, or can I get them up to labor and delivery? And as you can see, you know, the OB patients, they don't always read the rule book, and they're very rude, and they show up in your emergency department and they threaten to squish out babies. The good thing is most babies that are delivered precipitously, they're uneventful deliveries. They cause us to have meconium in our pants, but most of them do just fine. So remember your transport considerations if you're transporting them in the hospital or if you're EMS transporting them to the hospital. Very important that you guys are dividing tasks. Who gets mom, who gets baby? And then phone home. So have your doctor stork or have the hospital ready for you. So a lot of people are at the birthday party to help you. So the other thing is also remember these moms are going to be pretty anxious and they're going to be counting on us to be calm. For that breech delivery in particularly, it's a hands-off approach and we want to have very minimal guidance. And once the baby's out, I think that everybody deserves a drink. So we'll just let hospital administration know that I think this is a good idea. So, you know, I'll buy. Okay. So here's my last question. Your friend's been lost for 2 days. Are you going in to save them? Again, I think that's funny. Okay, and I'd like to end, first of all, I want to thank all my friends that work with me in UCAN. They help me make a ton of videos. Please pay careful attention to the dialogue between Kyle and Candace because it's hysterical.
3, action.
It's okay, baby. Okay. There's a nurse coming. They told me they would be right on their way, but it's okay because we're not having a baby. We're not going to have a baby. You're
Okay, we're going
totally
to
fine.
have a baby right now.
We're having a baby. We're gonna have a baby.
You are having a baby. Come forward. Okay. Support the perineum. We don't want my perineum. We don't want the perineum to tear.
No, please don't.
Okay. So push. Hand's gonna control the delivery. Good. Push.
You keep talking about the stones. I'm gonna break the stone.
But it was part of our plan.
Head's coming out. Okay, good. Now put your hands over the ears. Baby's gonna rotate. Perfect. Gently pull down to deliver the anterior shoulder.
You're fine. It's fine.
Pull up to deliver the posterior shoulder. And baby's gonna come out in a hurry. There. It's a girl! It's a girl! It's a girl!
Oh wait, the baby's born. Where's the baby, guys? Get out here. The baby's already born. I missed it. Okay, so let's take the baby off this wet blanket, guys. We've got to stimulate him. Now the baby's crying, so we know the heart rate is at least 100. So that's a great thing. So we're going to continue to stimulate. I'm going to put the baby on this dry blanket here. Oh, you know, everybody thinks you want to cut the cord, but you don't. You have to be very careful because you can cause infection if you don't have clean clamps or clean scissors. So you want to be careful. All right. So this baby's crying very vigorously. All right, we're ready for skin to skin.
I'm ready.
Mom first.
Oh, okay. Mom first. Thanks.
Beautiful baby. Thank you.
Okay, so guys, just a couple things about that fun video. Obviously, the umbilical cord fell off. In real life, it doesn't fall off, and it's okay to leave it. Remember, we want to have that delayed cord clamping. Don't even worry about the cord. Keep that baby either at the level of the perineum or skin to skin with mom, as we did. So don't worry about that. And Brenna was right. Any baby that comes out crying and screaming, you know, has a heart rate over 100. And you know is probably going to have an APGAR probably of at least 7 because they've got a good heart rate, they've got good cry, they've got color, they've got tone. And again, worrying about the APGAR after the baby's born. So please let me know if you guys have any questions or any concerns. This is my email. This is my cell phone number. Again, I also work in the hospital, so you can email me that way. And anytime that you guys have any OB patients that come in and you want to debrief, did I do things the right way? Was there something else I should have done? Please let me know. I'm your pal, right? I'm here to support you, and I'm hopefully going to make this a little bit less stressful for you. So if nothing else, I'm fun to drink with. So let me know. And that's it. So if you have any questions, let me know. Otherwise, thank you guys for attending this virtual lecture. And I hope it was helpful. And also, I'm going to be posting other videos for you.